Good morning, everyone. My name is Tarandy Panu, and I am Strategic and EDI plus Accessibility Communication Specialist at CERC in Health Equity and Community Wellbeing. Thank you for joining us today for our speaker series for the launch of the special issue on global healthcare systems and violence against women and girls, published in Health Sociology Review with Dr. Karen Soldadich, followed by a panel discussion with select authors from the special issue, Marcia Hinsmarie, Enya Lord, Mandy Hughes, and Louise Whitaker. Today's event is virtual, with audiences joining from all around the world. Live captioning is provided, so please click the CC button at the bottom of your screen if you need closed captioning. And just a reminder that our session today is recorded and will be put on our website at a later date for any viewing needs. Before we start, I'd like to offer a land acknowledgement that we are currently on the traditional territories of the Mississaugas and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum, an agreement to peacefully share and care for resources around the Great Lakes. I come to this land as a child of immigrants who found safety and a home here, which allowed them to grow and settle. I am grateful to have the opportunity to work on this land and call it my home, and by doing so, I give respect to all its first inhabitants, while also acknowledging that the rights and privileges afforded through immigration and through my birth in this country has given me benefits that many Indigenous nations do not have. This acknowledgement is not to belittle any other forms of marginalization we all experience, but to understand and bring attention to the fact that when we, as cultural practitioners, speak of and on issues around race, immigration, gender, disability, and socioeconomic status, that it should not be siloed from talking about the action against the vast issues faced by Indigenous folks in Canada and around the globe. I encourage you all to seek ways towards positive reconciliation and the navigating of your relationship with this land as current settlers and settlers of other nations that people are viewing in from. And I hope for a collective and full truth and reconciliation to start in these rooms, in these spaces, as we come up with tangible ways to work with Indigenous communities to call for action. Now, a little bit about CERC in Health Equity and Community Wellbeing. We are a transformative research initiative that employs an engaged community partnership approach to expand our understanding, practice, and delivery to health outcomes for all members of our communities. Through collaboration with a network of healthcare institutions, service providers, and civil society organizations, the program aims for a paradigm shift, one that challenges a siloed, expert-driven approach to health and well-being and moves towards a community-engaged preventative model of well-being. Uniquely applying a critical disability lens, the research program aims to not only reduce health disparities that are inextricable from their social contexts, but embedded in community knowledge into healthcare institutions, systems, and models of delivery. I do see that there is a hand raised. We will not be taking questions at this time, but if you do have a comment, please do put it in the comment section and I will address it. Thank you. And now to start our event, I'm thrilled to introduce our esteemed guests, starting with Marcia Hinsmarie, who is an adjunct professor of Black organizing and resistance. Her praxis focuses predominantly on Caribbean women's experience of womanhood in the Commonwealth Caribbean and its Canadian diaspora. She spent 23 years developing an advocacy model to address the issues of underprivileged groups of women in Barbados and the Commonwealth Caribbean. The major focus of the work is to develop and encourage the use of victim-defined services of women and girls affected by various types of gender-based violence, while at the same time removing the burden of eradicating violence from women and victims by focusing greater attention to systemic oppression and a stronger lobby in policy spaces. Enya Lord is an attorney at law called to the bar to practice in Barbados since October 2016. Her practice areas include matters that are characterized by domestic violence and family instability. In addition, she represents the interests of women and girls who experience injustice at the hands of the state. Her most recent accomplishments on behalf of vulnerable girls include litigation before the High Court of Barbados, resulting in a landmark decision which rendered the long-standing and discriminating charge of wandering unconstitutional. She coordinates the strategic litigation portfolio for the survivor-led nonprofit organization, Operation Safe Space Movement for Change, Inc., the OSS, and has appeared before the Caribbean Court of Justice on behalf of OSS to address the court on the legal and social issues of victims of domestic violence experienced on Barbados. Dr. Louise Whitaker, Senior Lecturer, Social Work and Community Welfare at the Southern Cross University in Australia, where she oversees the mental health social work curriculum in the undergraduate and postgraduate programs. Her research examines the social inclusion of women with refugee backgrounds and mental health social work practice and pedagogy. Before joining academia in 2010, she practiced in mental health, women's health, legal aid, and cancer workforce development. Dr. Whitaker is particularly interested in acknowledging and capturing practice wisdom through practiced social work research. And Dr. Mandy Hughes is a senior lecturer and social science course coordinator in the Faculty of Education at Southern Cross University, Australia. She teaches sociology and political science and is committed to fostering a love of learning to address inequality and promote social justice. Over the last decade, Mandy has developed long-term research partnerships with refugee communities and not-for-profit organizations in regional Australia. Her work uses co-design and collaborative action research principles to identify and respond to pressing social issues, including refugee settlement and domestic and family violence. She has previously worked in community and international development, including working in women's refuge that support women fleeing domestic and family violence. Thank you, everyone, for joining us. We are thrilled to have these select authors from our special issue, and we'll be starting with Karen Soldatich, the Canada Excellence Research Chair in Health Equity and Community Wellbeing, who is also the co-editor of this issue, to provide us a brief overview of the necessary work that is being done with this project. Karen, over to you.
Thanks so much, Terendip, and thank you so much to our presenters today who've been critical to the realisation of this special issue. Before we begin, I really want to follow up on Terendip's acknowledgement of land, but also acknowledgement of land in relation to Australia, where this special issue actually began. Unfortunately, Michelle Fitz, who co-led this special issue with me, is unable to attend. She is based in Alice Springs, which is in the middle of Australia. We really have been working together for an extended period of time. Michelle really since beginning her PhD, and myself since the early 2010s in the area of disability, and Michelle in the area of Indigenous women and acquired brain injury. Have been looking at this issue for a very long time, and how this issue really became about is through our joint work. What we began to really notice is that whilst the issue of violence against women and access to public health systems and different types of policies around that globally was beginning to be recognised and taken up, and in countries like Australia, formalised agreements governments were setting up through different women's groups and providing different types of funding for services. They often depicted women as a homogeneous group. And because I do a lot of work with disabled women, and Michelle does extensive work with Indigenous women, and our work really looked at this intersection, what we began to find quite troublesome was the literature really basically homogenized the issue of violence against women. So what we really wanted to do was to bring together a group of scholars from around the world through putting together a call for papers that would actually focus on the experience of violence against women who came from different minority groups and faced structural processes of stigma, discrimination, and bias in the ways in which the medical system worked with them, and to really begin to draw out what were the unique features. And this is one of the things that today's presenters are going to do, both from a scholarly and theoretical perspective, but as importantly, really drawing on their own activist scholarship, their own in-depth research, and their own legal activism in Australia and Barbados as two examples. But this theme of grinding within the empirical evidence and working with people who have lived expertise as victims of violence and particularly intimate partner violence really draw out in their papers. One of the things that we note is that often hospitals are inaccessible. So across the series, many of the medical professionals are not actually trained to understand the experience of violence, again, of intimate partner violence, family and domestic violence for different minority groups. Spaces and the way that especially emergency departments or emergency rooms, as they're called in the North American context, really don't have the facilities to respond appropriately or in ways that make women and their children feel secure when they go to those departments. Long-standing historical perspectives around Indigenous women, particular and ethnic and racial minorities, around mothering and white normative ways of mothering really undermine and discriminate them to the point where often Indigenous and highly racialised women won't even present to ED/ER departments because of the fears around loss of children, such as being reported to social workers who often will intervene, and because of the historical baggage of settler colonialism, really becomes very pervasive in those kind of frontline encounters for Indigenous and highly racialised minority women. So this issue was really about bringing together from around the world different perspectives that these women actually face and really giving air to this. So we can really think about not only that these unique policy moments as with violence against women becoming particularly prominent as a global policy discourse, particularly in places like the UN and UN Women, especially under COVID, women had experienced exponential rates of violence, but also to really bring in rigour around understanding, well, what does this mean for women who've always been marginalised from the global health system? What does this mean for women with disabilities who have children who can't necessarily show up at places and spaces that will be safe for them and accessible for them and able to support them as disabled mothers and to support their children? What does this mean for Indigenous women who've been highly racialised and experience day-to-day discrimination within their local health system? What does this mean for highly racialised and marginalised refugee women who often don't have rights or are in the process of obtaining citizenship? So thinking about all these aspects from a policy perspective, but also from a health institutional perspective and at the professional level, bringing it into a single dialogue and the way that they can talk to each other. To really get that dialogue going, one of the things that we asked our contributors to do was actually also review and read the contributions across the special issue. So when they were revising through the peer review anonymous perspective, so the normal academic standard, all papers underwent that, but they also were sent to the contributors so the contributors could actually see not just their own reviewer response, but also see what the others were presenting and think about what that might mean for their own work. So one of the things that happens a lot in this special issue, which is also unique, is a dialogue between the different contributors and how aspects of racism within settler colonial contexts, within highly racialised health systems, and the ways in which heteronormative understandings of gender, especially in intimate partner violence, really get played out in the normative literature within the health research in and of itself and with health systems at the macro, meso and micro scale. So they could really build rigor into their own frameworks and thinking about the uniqueness of their papers and what they offer this global dialogue to bring violence against women, all women, sexually and gender diverse women, disabled women, racially marginalised, ethno-religious minority women, Indigenous women, bring violence to an end, particularly with the intimate partner sphere. What I'd like to do now is really wrap up the kind of general presentation of how the special issue was formed. It is available. All of the papers are open access on the Health Sociological Review. And this was one of the reasons why we actually also chose this particular journal, is to ensure that papers could be read not just by academic audiences, but also by activists and professionals working in this space and policymakers, so they could actively take up this knowledge and integrate it into their own work to drive broader systematic change. So I'm now going to hand over to the next presenter, or actually to Tarandip maybe to introduce the next presenter and really begin from there. But thank you ever so much for participating and really engaging with this extremely important topic. At the centre, we are doing more work in this space within a Canadian context. So please hook into our website as well to follow up on that. Thank you. Over to you.
Thank you, Karen, for that introduction of the issue. We will be moving on to Mandy and Louise to do their presentation about their article. Please, Mandy and Louise, let me know when you would like me to switch the slide.
Thanks, Tarandip. If you could move on to our first slide, that would be fantastic. Great. Thank you so much, and thanks to everyone for coming along. It's such a pleasure to be here and to be part of this special issue. So our paper, we're hoping that some of you might have already read it, or that you will in fact read it. So for our presentation, we thought we would talk a little bit more about the broader context of our longer term research project, and then zoom in a little bit and talk specifically about the paper and the significance of the paper. But just before we start, I'd like to hand over to Louise to do an acknowledgement of country.
Thanks, Mandy, and yes, thank you everyone for the invitation to be here. I'd like to acknowledge that I'm on Yagara country at the moment here in Australia, and to acknowledge that this land was never ceded. And if there are elders present, past, present, and those who are emerging leaders for the future, I'd like to acknowledge their wisdom and thank them for the wisdom that they share with us. So I'm going to set the context before I hand back to Mandy to talk about this particular part, the particular project that we've covered in the paper. This paper, the next slide, please, Tarandip. So this has been quite an amazing journey, really. This paper comes out of a research partnership that's been established. It says here 7 years, and actually I was thinking it's possibly even a bit longer than that. We started in 2016, Mandy, myself and another colleague, Barbara Rugendijk, working with a local community organisation within the region of our university footprint, which is in regional Australia. We're on the coast area, as you can see there. And we have quite a lot of people who come to this area to settle from around the world, really. And there's a particular program which is called Women at Risk that draws women who have been through very traumatic experiences from a range of different countries and come to settle in this particular area. And so the local community organisation identified that this was a group of women who really were given some initial settlement support, but could really benefit from more support in terms of establishing themselves in the community. And so established a program to look at how they might improve the way that women are supported to settle into the community. They were particularly interested in thinking about employment, and they were thinking from a perspective that if women were able to be employed, they would have more autonomy, they would actually have more choices and be empowered. And in regional communities in Australia, employment opportunities are quite limited. And so they started this program with the thought of having a small program that would be a pilot initially and that would then be able to be developed and rolled out. So this research really has been very iterative and, as Mandy was talking about, very co-designed. So it was very much we gathered, the organisation along with us gathered a group of women who were interested in participating in programs such as this, and then worked with them on what would make a difference in terms of their employability ultimately, but also their connection to community. So the next slide, please. So this is pointing towards where we are, which is actually on the coast, in between Brisbane and Sydney. It was funded by Violence Against Women money because ultimately it was seen, even though a lot of what we talked about was employment and social inclusion, this was seen as being a process towards making sure that women were safer than they had been in the past. The program over the 7 years that we were talking about ended up with 200 women from, as you can see there, 36 different countries. And the program spread from, after the initial pilot, it was in Coffs Harbour, and then it spread out up the coast towards Brisbane, towards the Gold Coast and in the Northern Rivers is what we call it, so Richmond, Tweed areas. Next slide, please. So the program really moved from initially thinking about it in terms of an educational program targeting employment towards thinking much more broadly about promoting health and well-being, and that based on the literature, the concept that if you have a more well-developed social capital, then in fact you're going to have more access to housing, to healthcare, and to the networks that will get you in contact with opportunities for employment. So the program, as a result, focused on connecting to place, connecting to people, referrals into networks of support that were both formal networks, such as organisations that were around, as well as informal networks, such as groups of women who would then become support people for the women who were part of the program. The comment that you can see there, "I'm a woman, a wife, I'm equal," came as part of the project as women were starting to wanting to articulate what they wanted people to know about their circumstances and who they were. And so the program started to give people, the women, an opportunity to voice how they wanted to be known and understood in the community. Next slide, please. So the foundation of the program was actually listening to the women. Very much at the heart of it all was starting with the women, listening to what their circumstances were. And in particular, a key feature was listening rather than asking them about what was their story and where had they been or what might have happened in their lives. Instead, it was very much about, tell us who you are, whatever you would like to say, and feel that you can have agency in the process of what it is that you feel that you need in your life. And you can see from this quote that as a result of this process of really building relationships with women, with the women, that they then told us they were feeling better mentally, physically, and more comfortable. They also ventured out into the community a lot more and learned to swim and learned to pick up push bikes and go around the community and feel much more confident doing those things with groups of women and exploring the community they were now living in, which of course then built their self-reliance. Next slide, please. So another key feature of this program was that in addition to listening to the women, the program really listened to the surrounding community. So it was about integrating the work into the existing network of services, which I think is an interesting learning for health services as well. Health services don't necessarily think about the integrated network of services that they're part of and informal networks that the people that they are treating are part of. And so this was very much about thinking about referral pathways based on a network that was there and therefore value adding to what was in the existing network and therefore building professional and personal social capital. And so this became quite an innovative program because it meant that it was finding a niche that hadn't actually already been filled. And so next slide, please. So in 2016, there was the pilot at Coffs Harbour, which was the community I was talking about before. With this niche, it attracted further funding and so spread to further geographical areas. And in those geographical areas across 3 different sites, there were 2 things that happened with the program. The first was that we were saying to the women, would they like to go and use photo voice and actually go out and tell us about their experience of the networks that supported them? And they, in their agency, decided that what they wanted to do was to actually have some community art exhibitions, somewhat about their networks, but also about who they were and what they wanted the community to know about them. And alongside that, we actually documented the experiences of the women as well as mostly the staff about the nature of the programs and what worked. And so we have a toolkit that was developed that we now then use in teaching our students to prepare them to go and work in communities. And so the students that we have graduate with an understanding of this concept of listening deeply at the heart of practice and then thinking about how you integrate services rather than introducing a new service that everything else has to kind of fit into. And that led into some consultation with the women saying really they also wanted us to examine domestic and family violence. And I can hand over to Mandy to talk about that, which was the next stage of the project.
Thanks, Louise. Next slide, please, Tarandit. Thank you. So as Louise mentioned earlier, the program was funded by the Australian Government's National Action Plan to address domestic and family violence. But the program wasn't actually named as a domestic violence program because the feeling was that no one would come, because obviously within refugee background communities, there's a lot of fear and shame and actually admitting to being in a violent relationship was a really significant thing. So it wasn't presented as that initially. And so after a number of years of the women engaging and developing their skills and engaging with a whole lot of different opportunities that were provided for them in the community, we were really sort of waiting for them to want to discuss other issues that were important to them. And so eventually some of the women did say, well, they did want to discuss domestic and family violence in their communities and what could we do to support them? What could the program do to support that? So the next research phase became a phase specifically looking at domestic and family violence. So the aim of this next phase was really to have a look at what is the cultural gap that we have in understanding these experiences of DFV. Also, what are some of the specific stresses that refugee background communities face? So how do the day-to-day challenges, things like issues with employment, housing, language, acculturation was a very particular phenomenon that was incredibly challenging, but how do they all build on each other? How do they intersect? So, intersectionality was incredibly important here. And how do they contribute to these experiences of domestic and family violence? And also, how can this actually inform the responses? So how can these women be better supported? So another aim of this particular phase was to check assumptions that people already had. So we need to talk to the women. What are their experiences? What do they want? What's important to them? How do they think these issues can be addressed? So recognising the women's expertise was incredibly important. Here it links back to the whole idea of listening to the women deeply, and for the program to be responsive to the women's interests and the women's needs. And that also ties into our action research framework as well. So ultimately, it was really about how can we learn about how to better support refugee communities who are experiencing DFE. Next slide, please. So in this particular phase, in the specific domestic and family violence phase, we worked mostly with women from refugee backgrounds who had been part of the 3 E's to Freedom program. And most of the findings are these women's voices. So there were 5 women identified from different cultural backgrounds who wanted to participate in the study. Because we'd been working with the women for a number of years and starting to develop that trust, they were starting to feel comfortable. You know, they were used to seeing Louise and myself around. We would participate in activities that they were involved in. We sort of had, you know, quite a presence in the program, and so they did feel comfortable with discussing these issues with us. We also wanted to just broaden those findings by also talking to some key informants. So we talked to staff from the Refugee Health Clinic and also specialist domestic and family violence services, as well as other refugee settlement services that were in the community. So we were really able to build up, you know, quite an extensive picture of different perspectives on the issue and how the women can be best supported. Next slide, please. So the research questions that we were looking at, particularly in this phase, is we were wanting to know what are women's understandings of the multiple layers of family violence in their communities, because obviously it's an incredibly complex issue and there are so many factors that need to be considered and to be understood by health practitioners and social support practitioners and everyone working with these communities. So we needed to know what barriers do women face. What barriers do women face? So, for example, if they won't seek support, why is that? What's going on? But also, how can women actually be empowered to seek support? So what are some of the factors that contribute there? Next slide, please. So some of the key findings, and I won't talk about them too much because, as I said earlier, really hoping that you will read the article or that you already have. I guess the most significant one was just the compounding factors that impact violence. So I was talking a little bit earlier about factors like employment or unemployment, as the case may be. Also for the men in particular, so the women talked about their observations about the men in their community. And for example, in one particular community, there was a very high incidence of alcohol abuse and gambling. And, you know, how did those factors combine and how did that impact on violence? Also, if the woman was employed and the husband wasn't, and the husband was at home, how did that again? So we were looking at how these different factors built up and worked together to increase the incidence of violence. Valuing trusted relationships or warm referrals, this was incredibly important. So who were the women likely to disclose to? Who would they seek support from? That may well be a health practitioner because they already have an established relationship with them. They already have a reason for seeking support. And again, over time, building up these relationships can mean to seeking more support and disclosing a violent relationship. Ultimately, we found that having knowledge about rights and the pathways to support, so knowing how to get that support, but also wanting to get that support, feeling safe and feeling that there is some level of trust, meant that women were more likely to act on the violence. Next slide, thanks. So I've just put up a couple of quotes from the article, from the findings. I won't read them out, I'll let you just have a look through, but you can see a little bit of a sense of the different facets and the complexity, I guess, of this issue. So you can really see some of those keywords coming up there: trust, pressure from the community, empowerment. I think that they're really significant, and of course, agency. Next slide, thanks. I'll just hand back to Louise just to wrap up and just give you a bit of a snapshot of the study's significance. But just something I wanted to point out is that this research was done to have value in the community. So it was produced to support people who are actually working with the women and supporting them. So initially we gave presentations to different community organisations, and a report was disseminated amongst different community groups. So it was all about fostering collaboration between different organisations and working together and seeking to develop a deeper level of understanding. Louise?
Thanks, Mandy. The other thing that came out of that conversation that Mandy was talking about with the broader community and with the women is that a men's group developed, facilitated by a man, and in fact it has really taken off. You know, it actually has been very successful. The men have participated in the group and started to think about how they might feel included in the community and therefore less vulnerable and more likely to be able to think about and talk about violence in a way that they can then address it. So some of the broad comments in terms of the study's significance. Well, clearly the study really opened up and talked about this understanding of the context of domestic and family violence for these women and children, so that then we can start to think about preventative measures and responsiveness of healthcare services. So preventative measures including all that we've talked about in this presentation and what we were covering in the research, and then starting to think about healthcare services that are able to link in with other services and recognise that a trusting relationship actually means that to take time with women, really, and to allow them time of when they're ready to talk, and to make sure that they have safety plans if they need them. It also identifies the difficulties faced when negotiating life in a new culture. You know, that there are incredible challenges in terms of being in the situations that the women find themselves in, and to really honour that and respect that. And finally, that the study really spoke about this investment in multiple responses, that it's really important to be thinking about services and how they interconnect. I've said that a few times. So that was clearly a finding from the study, because we often see that services, a new lot of services are rolled out, and certainly we see this in Australia, and there's a lot of change in terms of service structure, which is pretty stressful for people who are working in the services and pretty confusing for people trying to find the support that they need. And our final slide really speaks to the papers that we've written, and the final one, and that these are all captured in the paper that's part of the special edition. So thank you. I'll hand back to you, Tandeep, or to Mandy first.
Thank you, everyone. Appreciate your interest.
Thank you, Mandy and Louise. That was amazing and a lot of insight. For those in the audience who do have questions, the Q&A is open for you to type out your questions, and we will address them at the end of our speaker series today. Now I'd like to hand it over to Anya and Marcia to present their lecture.
Thank you very much. Good morning to everyone. If we can have the first slide, please, Tandy. So, as you know, projects, as they, materialize, they go through various stages of naming and conceptualization and that kind of thing. And one of the early working titles for this work was Finding Space in the Global Health System for Women and Girls Living in Plantocratic Patriarchal Culture. We're thinking and talking about the experiences of women in the Global South, in the Caribbean in particular. Next slide, please. Annie and I are doing this work as a part of a non-governmental organization that we work with. The organization is called Operation Safe Space. And in choosing the name for the organization, we are realizing and recognizing that within this plantation society, I talk about that a little bit later, there are very few safe spaces. And even those spaces that are supposed to be safe are not safe because of the pervasiveness of this culture. So one of the things that we really wanted to do with this non-governmental organization was to make sure that we were working in a decolonized way, that we were working with the needs of victims and survivors of all forms of gender-based violence, including intimate partner violence and childhood sexual violence, that there was a way of working with these women over time, not in project cycles. And it is one of the first times, I think, in the history of non-governmental work in Barbados that the women who run this group also publicly disclose as being survivors. A part of the plantation culture is that the society is very stratified. And so by the time you get to be a middle-class woman or a professional woman, there are certain silences that happen such that we think about and talk about gender-based violence as affecting those women or a different type of person. And we really wanted to make sure that we were pushing back against some of that characterization and opening space where we could all work for a collective freedom and liberation. So, like I said, we are survivor-led and we use client-centered advocacy as our main kind of mode of engagement. Next slide, please. So like I said, we're thinking and talking about Barbados. Barbados is a 166 square mile, relatively flat island. We characterize it as a part of the Commonwealth Caribbean, not because we don't understand that that is a problematic title, but because it is perhaps the best of a few problematic titles that we have. Things like the Anglophone Caribbean, which is not accurate because some of the islands that are termed Anglophone also have Creoles with different bases, such as St. Lucia, where there is standard English, but there is also a French-based Creole. We have the British Caribbean. Again, I think that is more problematic than the Commonwealth Caribbean. And of course, we have the West Indies, which has lost its allure because of it being a part of the colonial lie that is tied to Christopher Columbus. So I just wanted to kind of give a sense of when we think and talk about the Commonwealth Caribbean, it's not that we are choosing that because we think there is any goodness, but we're trying not to do as much harm with some of the other titles as we could possibly do. The Commonwealth Caribbean region is made up of a group of mainly islands and territories. Guyana is also there, and it's a part of the South American continent. And I want to say that the research that we're doing in Barbados is relevant in many ways across that grouping, and perhaps wider too in the Global South. But we also want to recognize that for a very long time, these communities have been homogenized, and we want to make sure that we're also not doing that. So while we recognize that, you know, there are some similarities and ways that our research and what we're thinking about is relevant, we also want to kind of, you know, accept and recognize that there also are differences that it is important to understand and accept. Next slide, please. So in terms of the methodology of the study, how did we kind of approach this? Anya, as you would have heard in the introduction, runs our strategic litigation unit in Operation Safe Space. And as we intake clients, we recognized that we were getting some very valuable case study information with each of the intakes. And we are cognizant as well that, you know, there's a kind of exoticism that goes along with living in the Caribbean. Everybody wants to come, everybody wants to do research. And there is a way in which, you know, there can be an exploitative element to asking people to talk about their experiences over and over again, especially when there's no monetary or other gain for them. And so what we did as a part of our intake process for strategic litigation cases, we talk to the people, the individuals that we're working with about the importance of research and having their stories help to contribute towards policy change and social change, and how research can be a part of doing that. And then we have them to sign a form if they're so minded, it is not mandatory, where we can then take their experiences and turn them into case studies for various types of research projects. And we think that this is a type of research efficiency, which, like I said, is very important in the context of the Caribbean, where people are sometimes exploited in the research process. We were thinking and talking about the global health system in a way that McKittrick 2010 encourages us to do in their Science and Other Stories. So we were asking questions differently to be able to arise or to come to different answers. And so McKittrick talks about how circular the research or the academic process can be. You're asking kind of the same question, you're using a body of literature, you're just stepping outside of it by one or two expansions. So we wanted to kind of take on the challenge of McKittrick to do a little more with this, with the research space, and to step beyond you know, some of the traditional boundaries and the traditional ways. And when I get to talking and thinking about how we constructed the global health system, you'll see how we did that. We also are using this as research as resistance, the way that Straga and Brown 2015 categorize. Next slide, please. So in terms of our definitions, of course, the first thing that we wanted to talk about and think about was this global health system. What is it? How are we thinking about it? And this is one of the examples, like I said, of how we asked questions differently for different answers. Everybody kind of assumes when we're talking about the global health system that it's a positive thing, but we wanted to think about how the global health system is a colonial enterprise, how it reproduces problematic power relations and oppression, how it can be harmful to certain groups of people, how it is disjointed from different groups of people. And then if it is disjointed, what are some of the connectors into the global health system? So when we think about it traditionally, we don't think of things like the judicial system as a connector to the health system. We don't think about the police as connected to the health system. We don't think about civil society as connectors to the health system. And this is what we are encouraging individuals to do. As you would have heard the presentation, I think it was Louise who mentioned as well, you know, that it is important to have connectors within these systems because of the way that people's lives are constructed and how people negotiate their lives. We also wanted to highlight white benevolence and how it has been used to be harmful to populations in the global south and indigenous populations in the global north over time. And we wanted to also highlight that we see the global health system as also having elements of that white benevolence inside of it. And so we problematized the global health system in this way. And then we were thinking about the connections between the global health system and a plantocratic patriarchal culture. Next slide, please. So we are thinking about Barbados and the rest of the Caribbean as these plantocratic patriarchal cultures. And this term was given to us by Fogg Alwig in 1995. And I feel as though it's kind of gone by the wayside, but I think it's a very useful term because what it does, you can click again, is that it connects or society and how it is run to the patriarchal system that was developing in Britain, and Fogg Alwig outlines that and shows then how coloniality has really affected our society and of course gender performance in the society, and then of course how that feeds into various elements of gender-based violence. And if you click again, so basically using the example of the patriarch from the British society, the massa or the head of the plantation, the owner of the plantation, and then the people who helped to run the plantation in the absence of the owner in most cases, became that all-powerful kind of massa kind of metaphor. Next slide, please. And so how I am expanding this in the contemporary moment and thinking about it is that massa is not just something that plays out in work culture or in family culture, but it actually becomes embedded in the political and social culture of Barbados, such that all of our systems carry this element of male superiority, objectification of women, and all of the things that go along and around patriarchal culture and the construction of unsafe masculinities. And the final point there, if you click again, please, is that what happened at the level of the plantation or the level of the man being the head of the household is again also replicated at the level of the state. So anytime we're thinking and talking about the experience of women in any system in Barbados, we have to bear in mind that this is how the construction went. Next slide, please. And I'm turning it over to Anya. Thank you.
Good morning, everyone. Thank you, Marcia. So what I'm going to do in my presentation, I'm going to speak about my experience as an attorney at law, working with vulnerable persons and the role of the healthcare system, well, the role that the healthcare system currently plays and how we could actually improve that role, how they can play a greater role in working with the judicial and legal system as it relates to vulnerable persons. And when I speak about vulnerable persons, I am speaking primarily about women and their children and girls who are victims of domestic and gender-based violence. And I speak with respect to all forms of violence, because in Barbados, we do have this tendency to focus on physical violence only. And we tend to ignore the psychological and emotional impact of violence on these groups of people. Now, the issue with Barbados is that we do not have any recent prevalence study on the prevalence of domestic violence in Barbados. So when we speak about the prevalence of domestic violence, when we speak about statistics, we are relying heavily on what international trends say. And because of that, we really also don't know how domestic violence impacts the healthcare system and what the healthcare response to domestic violence and gender-based violence really is. These individuals will enter the system through various avenues, sometimes through the police, so that's through the criminal justice system. Sometimes the police may refer them to get protection orders, so that's more like a quasi-criminal approach. Very often, they will go to the system on their own through the magistrate's court to file their own family and civil proceedings. And then they sometimes come to us as attorneys at law through the high court or civil court system. And what we do see happening is that there's largely no recognition of emotional and psychological abuse, or the impact of it, I should say, on women who are coming into the system. Even where attorneys at law will ask for reports from specialists, reports tend very much to focus on the impact on the child, because the welfare of the child is usually paramount in those circumstances. But what happens is that the emotional and psychological impact on the women interfacing with the judicial system is largely ignored. And as a result, children continue to be forced to witness the abuse of women, their mothers, their aunts, whatever the case may be, because the way that it affects them is largely ignored. It becomes then a vicious cycle, because what you will see happening is that these women will continue then to go back into the healthcare system for emotional and psychological support, for psychiatric care, and whatever steps are being taken to help them, it almost is a waste of time, because the judicial system sits in almost like a silo on its own and doesn't put things in place to protect these women from continuously having to experience this abuse. The next issue that we have is that there is a complete lack of legislative framework that protects individuals who have mental health illnesses or who are disabled when they go into the judicial system. So our mental health legislation largely deals with protection and management of assets, and not with the care and control of these individuals, or what procedures and policies and steps are to be taken when you are dealing with their psychological and emotional support. It's then left up to attorneys at law again to push the court to take certain steps or certain directions, or to ask for certain things to happen within the healthcare system for the better protection of these individuals. And this was something that we saw with Zara, who is the subject of case study number 1 here on this slide. She was or is an individual with a mental health illness. She was a normal child, and unfortunately she experienced cognitive decline. As far as I understand, it was a form of schizophrenia. She went into the police station through a family member under false allegations of sexual assault. And her parents recognized that the police had to investigate, but unfortunately, they were largely ignored as it related to her mental health condition. And although they presented evidence of the fact that she needed medication, although they presented evidence of the fact that she was in the care of the psychiatric hospital as an outpatient, her circumstances were largely ignored. By the time I contacted the police station, what I was told was that she's 18 years old. Well, at the time 19, she's an adult, and therefore there was nothing that I could say or do to intervene on her behalf with them. And essentially what we really wanted, and all we really suggested at that stage, was that you have individuals from the psychiatric hospital or a psychiatric nurse sit with you during the interview process, so that she is not re-victimized in the process. So that in itself is probably the most recent example that we have of how the legal system and the healthcare system don't work together to assist persons who are victims of gender and gender-based and domestic violence. Thank you.
I'd like to thank Karen, Marcia, Enya, Mandy, and Louise for your time and for joining us from various time zones. It's very late in Australia, so I really do appreciate you making the time for us. I would also like to thank Angie, who is our live captioner, and the CERC Health team for their support. And thank you for all of you attending and engaging with our talk today. Our next event will be on November 7th, titled Disability Accommodation in the Workplace, with Dr. Ravi Malhotra and Emily Ruppel. Please do check our website for registration details and more information about events to date, including this one, which will be released in the coming weeks. Thank you, everyone, and I hope everyone has a great day.